Persistent groin pain after total hip arthroplasty or THA can be frustrating for patients and challenging for clinicians. While most people recover well from hip replacement, a small percentage experience ongoing discomfort. One often overlooked culprit is Iliopsoas impingement, a condition where the iliopsoas tendon becomes irritated by the artificial hip components. This video will guide you through the causes, diagnosis, and management of Iliopsoas impingement after THA, helping you understand why early recognition and treatment are so important for optimal recovery and quality of life. Iliopsoas impingement typically arises from mechanical irritation of the iliopsoas tendon. This can happen when the front edge of the hip socket component, leftover cement, or long screws protrude into the path of the tendon. As patients move their hips, especially during activities like climbing stairs or standing up, the tendon rubs against these structures, leading to inflammation and pain. Sometimes, even subtle changes in leg length or hip alignment after surgery can contribute to ongoing irritation. Recognizing these mechanical factors is key to understanding why some patients develop persistent groin pain after hip replacement. Iliopsoas is a powerful muscle group made up of the psoas major and iliacus muscles. These muscles originate from the lower spine and pelvis, joining together to attach at the lesser trochanter of the femur. The iliopsoas is the main flexor of the hip, allowing you to lift your knee and stabilize your posture. During hip replacement surgery, changes to the anatomy or placement of artificial components can alter the relationship between the iliopsoas tendon and the hip joint, sometimes leading to impingement. Understanding this anatomy is crucial for both diagnosis and treatment. Patients with iliopsoas impingement often describe persistent, sometimes severe groin pain that worsens with activities like climbing stairs, getting in and out of bed, or rising from a chair. Some may even need to use their hands to lift their leg due to discomfort. A snapping or clunking sensation in the hip can also occur. On examination, passive hip movement is usually pain-free, but active flexion, like lifting the leg, triggers pain. Subtle signs such as a limp or tenderness in the groin may be present, but walking is often not painful unless the hip is actively engaged. Diagnosing iliopsoas impingement starts with a thorough clinical assessment and is followed by targeted imaging. Standard X-rays help assess the position of the hip components, especially looking for any overhang at the front of the socket. If X-rays are inconclusive, CT scans can provide detailed views of the implant and surrounding structures. In some cases, a diagnostic injection of anesthetic into the iliopsoas tendon sheath is performed. If this relieves the pain, it confirms the diagnosis. Advanced MRI techniques and ultrasound can also help visualize soft tissue changes and guide injections, ensuring a precise diagnosis. Initial treatment for iliopsoas impingement often involves conservative measures. Rest, anti-inflammatory medications, and physical therapy are the mainstays. Stretching and strengthening exercises, especially those targeting hip extension and rotation, can help reduce symptoms. Physiotherapy may include assisted movements and ultrasound therapy, while gait retraining focuses on stabilizing the hip during walking. In some cases, corticosteroid injections into the iliopsoas bursa or tendon provide temporary relief, allowing patients to participate more fully in rehabilitation. However, these approaches may not always offer lasting results, especially if mechanical irritation persists. Corticosteroid injections are commonly used to manage iliopsoas impingement, especially when conservative therapy alone is insufficient. These injections, guided by imaging, can reduce inflammation and provide pain relief for several months. However, studies show that while some patients experience significant improvement, the effects are often temporary. In many cases, symptoms return and further intervention is needed. The success of injections varies, and their role is often as a bridge to more definitive treatment, rather than a permanent solution. Patients should be aware of the potential for recurrence and the need for ongoing evaluation. Conservative measures and injections fail to provide lasting relief, surgical intervention may be necessary. The most common procedure is iliopsoas tenotomy, where the tendon is released to eliminate impingement. This can be done through open or minimally invasive arthroscopic techniques, each with its own advantages. If imaging shows that the hip socket component is protruding, revision surgery may be required to reposition the implant. Surgical management has a high success rate, with most patients experiencing significant improvement in pain and function. The choice of procedure depends on the underlying cause identified during evaluation. Iliopsoas impingement is a significant but often under-recognized cause of groin pain after hip replacement. Accurate diagnosis relies on careful clinical assessment and targeted imaging, while treatment ranges from conservative therapy to surgical intervention. Early recognition and a structured approach are essential for improving outcomes and reducing unnecessary delays in care. With advances in surgical techniques and the adoption of robotic-assisted hip replacement, the precision of implant placement continues to improve, potentially reducing the risk of this complication in the future. Ongoing research and clinical experience will further refine management strategies for affected patients.